financial burden, social isolation and abandonment, public insensitivity, and an unsupportive work environment. So we want to prevent those things from happening, all right? So we know that with patient education, there's a lot of things that we can help prevent. We don't know who's going to get lymphedema. We know a lot of information is kind of mysterious out there. We do know that people who have been educated and know what to look for have a much lower risk, and just knowing more information helps them to recognize that they may be developing the signs and symptoms of lymphedema, where it can be addressed early on and have fewer symptoms. So who is at risk? And I know there might be some folks out there tonight that this is information that is appropriate for anyone who has had any kind of cancer. So the people at risk are folks that have had lymph node removal at any level, whether it's a complete axillary node dissection or whether it's just the sentinel node dissection. We know that you're still at risk. Persons that have undergone radiation therapy, folks that have obesity issues, people that following surgery had any kind of delayed wound healing, and if there is a tumor obstructing the lymphatics flow. The incidence with breast cancer survivors has probably been one of those mysterious things that you've probably heard different numbers. I know I've heard different numbers in the years that I've been a lymphedema therapist. We think that it's pretty well narrowed down to these numbers that we have here now. So approximately 0 to 7% are diagnosed with lymphedema if you've just had a sentinel lymph node biopsy, and approximately 15 to 20% of breast cancer survivors will have lymphedema if they've had a complete axillary node dissection. Question mark, is this underreported? Is it underdiagnosed? Very real possibility of that. We know that many years that it just was ignored, but we think these numbers are pretty accurate now. So my objectives for tonight is to teach you a little bit about the basic anatomy and physiology of how your lymphatic system works, tell you what the definition of lymphedema is, give you information about the causes and classifications of lymphedema, how we diagnose lymphedema, what the staging and characteristics are of once it's diagnosed, how we treat, what the treatment options are, what some recent advances in care are, and also to give you probably the most important part of some risk reduction strategies. So just a quick overview of the anatomy. The lymph capillaries are the structures that are closest to the surface of your skin. They absorb the cellular fluid and waste products from what's called the interstitium, and that's the lining between your skin and your muscles. So there's fluid that floats around in there, and your capillaries, lymph capillaries, absorb that fluid. Then we go into a little bit deeper level, and these are a little bit larger, the lymphatic collectors. They collect that fluid and they start transporting it towards the lymph nodes. The lymph nodes work as filters of foreign substances in our bodies. These things can be cancer cells, they can be proteins. Sometimes there's infectious tissues that are broken down in there. And they help break those down as well as fight infection. Deeper than that are the lymphatic trunks. This gets a little bit larger, and these transport the lymph deep into the body. And then we go into the lymphatic ducts, which reconnect with the venous circulation, and the fluid is then put back into your blood circulatory system. So the superficial lymphatics, which are the ones that I can affect the most when I'm treating somebody, they drain the skin, and the closer to the surface. The deep lymphatics drain the rest of the body. And here we have a little bit of a schematic of what I just reviewed. So here's your heart up here in the top, dumps blood into your arteries, that goes down into your blood capillaries. And then the blood capillaries are what dump some of that fluid into your interstitium, and that's where the lymph comes out. These little green lines here are your lymph capillaries. Those capillaries take it into the lymph collectors. The lymph collectors take it into this bean-shaped item, which is your lymph node. and it keeps going through until eventually it dumps back into your venous system, and then the whole process starts all over again. And this is a schematic of those deeper structures. So up here we have the right lymphatic duct. So that lymph duct puts the fluid back into your subclavian vein, and the left, on the left side, the thoracic duct puts it back into the left subclavian vein. And you can see here, this was just recently pointed out to me, and I hadn't really given it a thought before, that this purple section is only taken care of by the right lymphatic duct, and all of the rest of the green is drained on the left side. One of the statistics is kind of interesting, and I wonder if it's not because of the fact that the left side has to take care of so much more of the body. Statistically, we know that women and men that have had breast cancer on the left side have a higher occurrence. So, there may be a little bit of a connection there. Your lymph fluid is transparent and yellow. It's similar in nature to like the fluid that you would get if you popped a blister. This is formed when the fluid leaves your capillary bed. So again, that fluid that's pushed out into the interstitium, approximately 10% of your blood volume becomes lymph fluid. It's made up of water, proteins, lipids, carbohydrates, ions, and cells. And that tells you that it's not just fluid. If it were just fluid, we could drain it out by giving you diuretics. So what is the definition of lymphedema? Lymphedema is an accumulation of protein-rich fluid due to the mechanical insufficiency of the lymphatic system. So again, that fluid that is not just water, it's not just liquid, there's stuff in there that makes it heavier and harder to process. And it's been interrupted. Something in the system has gone wrong, either mechanically because of trauma or because of something that's been malformed in development. It occurs again when there's a damage to any part of the system, or when the lymphatic load exceeds the capacity of the system. So if there's too much fluid in the system and it's more than what your lymph vessels can handle, that lymph gets left behind in the tissues in that interstitium area. Sometimes that happens most common with people who have vascular insufficiencies. They don't necessarily have anything wrong with their lymphatic system until their veins start leaking more and more fluid, and eventually the lymphatics can't handle it. So we have two different classifications of lymphedema. The first is primary. That is congenital. So a person is born with it. There's something wrong with their lymphatic system at birth. It's typically hereditary. So you'll see generation after generation that have one leg larger, or sometimes one side of the body has fluid that accumulates. It typically develops only in the lower extremities. Then we have secondary lymphedema. And this is again when something following birth happens to the system. Because of surgery, lymph nodes are removed, radiation, which causes scarring in your lymph nodes. It can be post-traumatic. So if somebody has a crushing injury in a car accident or something of that nature. Believe it or not, it can be self-induced. There are people who have mental health issues that will tie a tourniquet around their leg or their arm and end up with a very swollen extremity and go to the doctor and say, I don't know what happened. Venous insufficiency that I just mentioned a little bit ago. Sometimes a very bad infection can cause the lymphatic system to shut down and get scarred over. And of course, malignancies. So again, if there's a large tumor that's blocking the flow of the fluid, we know that can cause lymphedema. So how do we go about diagnosing lymphedema? There's lots of different things that come into play. There's a technique called water displacement. This is when a body part is immersed into a tank of water, a tub of water, something of that nature. We determine how much of the water is actually been displaced. So we know when we go into a bathtub, the water level is here. And when your body gets into it, the water level goes up here. So there's a measurement of how much of that water actually comes out. It's determined that someone is diagnosed with lymphedema if there's 200 or more milliliters that have been displaced. This is comparing it to the opposite side. So say somebody has swelling on the right side, you do this technique on the right side, and then you do the same thing on the left side. It's not used very often because it's cumbersome, it's messy, it's difficult to position people properly to make sure that the same amount of the limb is actually submerged in the water. So it's not used very often, but it is very, very accurate. We also know that there's an infrared laser parameter. This is very similar in nature to a CAT scan. They use infrared light. A cross section is taken about every 3 millimeters. Then the measurement of those 3 millimeter markings are put into a computer where they calculate the limb volume. This is typically not used because it's expensive. They've just recently come up with portable units, and the body part must be repositioned exactly in the same position each time, or it loses its accuracy. Bioimpedance analysis. The name brand of the machine that's most commonly used out there is called an LDEX. It takes a measurement of the water content within the tissues, passes a current through the limb. They measure the amount of resistance to that. We know that the frequency of the electrical current can only travel through actual fluid that's in the interstitium. So again, in that layer between the skin and the muscles. As that increases, the resistance decreases. So there's a measurement. They've come up with a norm that tells them whether or not it's flowing at the right pace or whether there's more resistance or less resistance. And they compare that to the opposite side. So they can have a really good accurate measurement of that. Great machine. I wish we could have one. I have looked into it for my own clinic. It's $5,000 a month just to rent the software. So that's not happening in my clinic. I believe Roswell has one, but I'm not 100% certain. Circumferential measurements are probably the most common way that lymphedema therapists utilize, determine whether or not somebody has what we would consider likely have lymphedema. We take a tape measurement and we measure a limb at defined measurements. Sometimes it's every 4 millimeters, sometimes it's every 10 centimeters, excuse me. Really depends on your school of thought. Again, we put those numbers into a formula that determines total volume. What we're taught is that if there's about 200 milliliters difference in limb volume or 10% volume change, that somebody is considered to have lymphedema. We also have been told that if there's any spot in those markings that there's 2 centimeters or greater difference when you're comparing it to the opposite extremity, that we can consider them to have lymphedema, or if there's a 2 centimeter increase at any one point when you've compared it to previous measurements. I'm not quite that fine-tuned. I don't think one area of measurement is good enough for that. I like to have a little bit more. If there's several locations that are showing an increase, then chances are I'm going to determine it then, but not with just one difference. There's too much chance for it not being reliable if you're hitting the spot at a little bit different area than what you did before. Somebody maybe is retaining a little fluid, but they're really not any much different. So, but this is probably the most common way that most of us therapists determine. And then in addition to that is honestly subjective history from our patients. If somebody comes in and they're telling me they've had a swelling in their leg or their arm, and I ask them questions like, have you had a cancer diagnosis? And what type of treatments did you have when you were had your diagnosis? So if they've had radiation therapy, if they had lymph node dissection, how many were taken out? How long ago was it? What are their current complaints? Are they aware of a change in their limb? Does it feel like the clothing is fitting differently? Have they had a possible insult to the limb, i.e., have they had an infection? Did they by chance get a flu shot on that side? Is it feeling heavier, or did they have any kind of trauma to it? So we piece all those things together, take measurements, and then we can determine if it is likely lymphedema. So we go on to staging and characteristics. And this is how we can determine where someone is at in the process. The latency phase is where you want to start with treatment if you ever are possibly thinking that there is a possibility you have lymphedema. Latency stage is when there's a change in the transport capacity. So in other words, somebody has likely had surgery, they've had lymph nodes removed, that affects the ability of your lymphatic system to transport that fluid. There may not be anything that's visible or palpable. We might not be able to see any difference or any measure anything different, but there's subjective complaints that are pretty consistent. Someone who is at risk, who comes into me and says, my arm is heavy, my arm is aching, it feels tired all the time, I'm constantly rubbing my limb and it doesn't make it feel any better. Chances are something is changing in their body. And if we had an LDEX, we could probably determine that there's a difference. But just those things alone are going to trigger me to say, let's do a little intervention here and see if we can't reverse this at this stage. Stage 1 is also still reversible. There, excuse me, a person has started to accumulate some fluid. And again, it is that protein-rich fluid. Typically the tissues are going to be pitting. So if you push into it, there's going to be an indentation that's left in that skin. Usually in these early stages, if there is swelling present, it will reduce overnight, or if the arm is or the leg is elevated for a period of time, it'll reduce. And there's no skin changes that are occurring yet. Stage 2 is where we consider it irreversible. It's not going to just take care of itself. Again, much more accumulation of that protein-rich fluid. Pitting becomes progressively more difficult because the tissues are becoming so full that you can't even put your finger into it and cause an indentation. There's a connective tissue proliferation, which leads to this fibrosis that I mentioned. Fibrosis is when there's skin changes. It starts feeling really thick and really hard and really rigid. And there is no change in the amount of fluid in the limb overnight or with elevation. Stage 3 is where it starts getting ugly, and this is lymphostatic elephantiasis. These are the pictures that if any of you have dug around on the internet to find out about lymphedema, these are always the scary pictures that come up and scare the bejeebers out of everybody and think, oh my goodness, I've been told I have a chance of getting lymphedema and this is going to happen to me. Doesn't have to be this way, especially since you guys are here tonight and you're able to learn some information. So this is when, again, we've got more and more of that fluid in the skin. There is absolutely no pitting. There is fibrosis and sclerosis. And this is when it's really hard. If you push on that tissue, it doesn't even feel like skin. Elephantiasis it's called that for a reason, because if you think about what an elephant's skin looks like, that's what these people's skin actually looks like. There's papillomas, which are little outgrowths, little almost look like tumors. Hyperkeratosis, which is a dry flakiness of the skin. It can weep and leak of fluid because there's no more room in that limb for the fluid to be. So it literally just weeps out of the skin. And oftentimes a person with this level of lymphedema will develop cellulitis. Very, very prone and susceptible to infections on a regular basis. So these are the different stages. Stage 1, I was taught that this is stage 0, but there, depending on the school and the train of thought, this is your latency phase of lymphedema. If you look at this lady's arms, they're virtually the same. You can see veins and tendons in her fingers, and her knuckle creases are very, very visible. Might be a little bit of subtle change in the forearm, but for the most part, she really doesn't have any much symptomology. Stage 2, in my world, it's stage 1. This is again is the spontaneously reversible phase. Again, where we want these 2 stages are where you want to start getting treatment if you start developing symptoms. You can see here, when you compare this size of her arm to that one, there's a significant difference beginning. You can see she's losing her knuckle creases here, and her tendons are very less visible. This, you would be able to stick your thumb or your finger in there and it would leave that indentation. Stage 3, or again, stage 2 in my world, this is where it becomes spontaneously irreversible. So without, even with treatment, we are not going to make this entirely go away. This, you can see here, the arm is significantly larger than her right arm. The back of her hand is significantly swollen. She's got a crease here at the wrist that she doesn't have in the right arm. And over here in stage 4 and or stage 3 in my world, she is definitely well beyond this stage and needs intervention and needs it quickly. She doesn't have a lot of the changes that are really bad and really scary. This is still probably relatively soft, but you can see how much more swelling she has in this limb. And it's just filled with that protein-rich fluid, and is probably pretty uncomfortable and very, very heavy for her to be hanging on her body. So how do we treat lymphedema? Medications have been used over the years. Diuretics are ineffective. I already mentioned that earlier. And that's because it'll get rid of the fluid, but it doesn't get rid of the junk, the waste products, the protein molecules that are left behind. And those are the things that causes the skin changes. So you can take all the fluid out you want, but if you don't get rid of the rest of the stuff, there's still a problem in the lymphatic system and you're going to end up with problems. Benzopyrones have been determined fairly recently again to be effective at reducing and softening. These have mostly been used in Europe. I don't even know if they're legal in the United States to use for lymphedema anymore. I know I was taught that they should not be used, and mostly because of the toxicity to the liver and side effects that it has. Recently, there was a really good study that was done using ketoprofen, which is an anti-inflammatory. This has been used and has shown really good promise for reducing inflammation and softening of the tissue. So again, somebody that's in a later stage of the disease process benefits from this. After reading the study, I referred a few of my patients to their doctors to see if they could try a short course of this. And it's been pretty effective in again, softening the tissue and helping to reduce the skin changes a little bit. Doesn't take their symptoms away, but it definitely made them better. Compression pumps, very commonly used. Oftentimes, unfortunately, for a lot of physicians and even other people out there, it is the first line of defense, and it shouldn't be. And the reason it shouldn't be the first line of defense is because it only provides temporary results. Just like the medications, it will eliminate the fluid, but it will not move that protein component of the fluid. So when we use them, it's best used as part of a maintenance phase after they've had treatment from someone like myself, and to help maintain that. The other secondary effect, it can lead to edema in the trunk. So if you've got it in your leg, you got it in your arm, and you're just using a compression pump on that extremity, it can push the fluid into the trunk. Sometimes it pushes into the genitalia. So again, it should not be used as a standalone treatment, unless there's really absolutely nothing else that somebody could do. I had a patient once she was an older woman, and she was a breast cancer survivor of something like 35 years. So she had her breast cancer surgery way back in the day where they just dissected everything. Took all her lymph nodes, took all the breast tissue, radiated her up the yin yang, and her arm was literally a club. Her fingers couldn't open anymore, and it was just so uncomfortable for her. There was no way for me to have really treated her. I couldn't use compression on her. So we got her a compression pump just for comfort purposes, and it did help her. Complete decongestive therapy. That's what I've been trained to do. That's when a patient comes in to see me. This is typically what I'm doing with them. This is still at this point in time considered the gold standard of care for lymphedema. There are 5 components of complete decongestive therapy. The first is manual lymph drainage. I apologize for the little words all over the place there, but I stole the photo obviously and didn't ask permission for it. So what I do with my hands basically is I'm stimulating the lymphatic system, and this shows the lymph therapist doing just that. It's a very gentle, light touch massage, for lack of better terminology. And it's used to basically steer the fluid to the direction that we want it to go so that it can be processed by another part of the anatomy. So if this person has lymphedema of this arm, we're going to start over here in the trunk and the neck area, work our way down the arm, and then work our way back up. So you're stimulating as you go, and you're moving it as you come back. And the person is likely going to try to drive that fluid both down the trunk wall as well as across to the opposite side of the chest. We follow the manual lymph drainage by this multi-layered compression bandaging system. These are short stretch bandages. They are 100% cotton. They look very much like ACE bandages, but they do not have the elastic component to them. And the reason we use those is we don't want to allow that fluid to reaccumulate after we have done the manual lymph drainage. These are left in place to the best of possibilities for 24 hours a day, 7 days a week, until we get the limb down as far as we possibly can. And then we can transition into the maintenance phase where we get a compression garment. We also do lymphatic exercises. So we teach people specific exercises to help move that fluid on their own that doesn't require the manual lymph drainage. There's a really great video that's out there on YouTube. I wish I could find it again. I did look for it for this presentation and I couldn't come up with it. I thought I had it saved somewhere, where it actually shows manual lymph drainage being done and shows under fluoroscope the fluid being moved. And then they follow that up by having the patient do their own active exercises. And you see a similar effect when the patient is doing the exercises and in comparison to the manual lymph drainage. So movement and exercise is a very, very important component of lymphedema treatment. We also spend a lot of time with skin and nail care. It's important to make sure that your skin stays moisturized and that you don't have cuts, and you make sure that your cuticles are clipped but not broken open. You don't want any portals for infection. So that's why we emphasize the moisturizing and cleanliness of nails, et cetera, because that can lead to infection and a worsening of the symptoms. And the last phase is the patient education phase. So we teach a little bit about self-manual lymph drainage in some cases, where we teach somebody the direction to do that manual therapy to themselves. Sometimes we order a compression pump, sometimes we don't. We make sure we review the risk reduction strategies to prevent anything additional from happening. And that's something we'll go over before I finish up today. And again, final fitting for the appropriate compression garment that somebody is going to continue to wear during the daytime. There's also surgical options. Some are kind of exciting now because they're finding more and more headway on these things. So I just definitely wanted to touch base with you on them. There's something called a debulking procedure. This is reserved only for the worst case scenarios. So those people that have the really, really extreme skin changes in the stage 3 diagnosis, usually only done in lower extremities, and mostly because the skin changes can affect someone's mobility. Basically, they're taking off a large lobule, for lack of better terminology, of tissue and stitching it back up again. So it's a very extreme surgery, oftentimes do not heal well, but it can help someone's mobility. If anybody has watched that My 600-Pound Life program on the Learning Channel, that is oftentimes what they're talking about with some of the skin removal and or the lymphedema removal that they do on some of those patients. They're needing to move those tissues because there's no way to reduce it otherwise. Liposuction is showing a little bit more promise. This takes care of some of the fat that has accumulated, and it's a different type of fat. Again, this is what's causing that fibrosis and induration under the tissues. It's much less challenging to heal than the debulking procedures. Doesn't require any skin grafts. There's little scarring externally. Again, is only done on the stage 3 cases that are really, really severe and extreme. It is liposuction in itself is a pretty brutal procedure. So you need to make sure that it's done by a qualified individual as well as is done for good reason. And the liposuction itself also doesn't just change things. This person still has to maintain some kind of compression all the time daily in order to maintain the changes in the skin. This is where we start getting a little bit exciting. Now we're talking about some tissue transfers that are being done. These are being done primarily by plastic surgeons. The first one is called a vascularized lymph node transfer. This is where they're taking an area of tissue that has a lymph node or several lymph nodes along with the vascular supply, and it's transferred into an area on the affected extremity. There's a connection that's formed between the blood vessels and the lymph node flap and the recipient site vessels. So they're actually connecting those two things so that the flow of fluid can go through them. The success, they're not quite sure what it's due to, but they think it's probably partially due to what's called lymphangiogenesis, which is when the new lymph vessels form as a result of the reattachment. So similar in nature to a heart bypass. They're prior to having a cardiac bypass done, oftentimes the heart has already started growing, for lack of better terminology, growing its own vessels to bypass a blockage in the heart so the heart can stay healthy. So that's similar in nature to what this lymphangiogenesis is. They also think that perhaps this flap acts as a pump that's going to draw back the fluid to the venous circulation, and or it might act as a bridge over radiated tissue. So tissue that's been scarred and damaged, if they put this flap over that area, they think that it can just kind of bypass that blockage. Potential drawback, it can possibly cause lymphedema at the donor site. So you can imagine for somebody who already has lymphedema, the risk of having lymphedema in another extremity, you may want to think twice about that. So this image shows how it's done. In this particular case, they're harvesting the lymph nodes and the venous supply and the arterial supply from the groin area. And this is the patch along with the vascular and lymphatic system right here. They've opened up the tissue at this person's ankle, so obviously they have lymphedema in the opposite extremity, and they reattach that flap right into this area right there, and this is the completed surgery. I wish they had shown an image of how the limb made out, but this is still pretty early on in the process. Typically, these are only being done on stage 1 and 2s. And the next surgical procedure that I think is probably the most exciting, and I think personally has the most potential, is a lymphatic bypass, or otherwise known as a lymphaticovenous anastomosis. This is when they take the lymph vessels from the involved extremity and actually reroute it and or bypass to the venous system. They go around the lymph nodes that have been damaged. It's great surgical procedure because it's an outpatient procedure, very small incisions, very easy to heal. Again, most effective on stage 1 and stage 2 lymphedema. So before somebody even gets to that stage 3 or even comes close to it, they can do this kind of surgery. They are finding, however, that they have much better outcomes with the upper extremity involvement. So this next image is again, a schematic of, this is typically what happens inside of your system. You've got a vein, and there's a lymphatic vessel that's going along beside it. So what they're doing in this surgery is they're just cutting the lymphatic vessel off and inserting it microsurgically into the vein. So my next slide actually shows that this is real life. This is the bypass that has been done. So this is the person's vein here, and this is where they've taken that lymph vessel and they've reattached it to the vein right there. Oops, excuse me. All right, so pretty cool. Obviously very teeny tiny. You can see the size of here. A tenth of a millimeter is teeny tiny, so a half of a millimeter is like a quarter of an inch in reality. So what is promising about lymphedema care right now? Much more research is being done. So as opposed to what was considered the stepchild of medicine for many, many years, we're seeing that there's much more interest in lymphedema and its treatment. There's a huge center that's all they do in Australia is study lymphedema. They have come up with a lot of the procedures that are now being developed and progressed. So we know that there's, again, the success of these two surgeries that I just talked about. Also exciting is what's considered another gold standard of care is the prospective surveillance model of care. So a very large study was done going on 10 years ago, where they took a whole bunch of people that had breast cancer diagnoses, and they started following them at certain periods of time following their diagnosis and surgery. They taught patients information about how to prevent. They taught them the benefits of exercise. They were available to them in the event that there was some kind of change in the person's tissue. So they learned very early on through this study that early intervention reduces the risk of impairments. So that's an exciting development over the course of time. And also is there's better use of imaging. So we now have things that have been around for a little while that they're using more regularly to determine not necessarily a diagnosis, but how to treat once a person is obviously diagnosed with lymphedema. And I want to just show you a little bit about both of them. So the lymph scintigraphy has been around for a long time. This is something that's been used for many, many years. It's not done very often under average circumstances because typically, again, once somebody is just kind of determined based on signs and symptoms to have lymphedema, there was really no reason to do this because there wasn't a whole lot of treatment options for it. But what's done with this is there's a radio tracer that's injected into the body. The scanner follows the flow. They follow it through the lymph ducts and the nodes, and it can actually pinpoint where the obstruction can be. This is actually also utilized when they're doing the sentinel node biopsy during a breast cancer surgery. So they want to know where that first lymph node is that the breast drains into. So this is the same thing that they're doing, is this lymphoscintigraphy to follow that, to see where that lymph node is. So this image shows you what a lymphoscintigraphy actually shows. So this body here on the left has a normal lymphatic system. The radio tracer has been injected here at their feet, and you can follow the line right up. You can see how it's processed, and it goes right up into the trunks where it's actually dumped back into the venous circulation. This is an image of someone that had primary lymphedema, so somebody that was born with problems in their lymphatic system. You can see that most of that radio tracer is still just kind of sitting down here in their feet. There's a little bit of line going up here into the, whether it's the right or left leg, I can't tell if it's an anterior or posterior view, but there's a little bit going up, maybe a smidge here in the other extremity, but most of that tracer is just sitting here and going nowhere. And this last image shows you somebody that has lymphedema. It's not congenital. It is just unilateral. So it's just in the one leg. You can see where they injected it. Okay. And it's just, all of this is just sitting here in the superficial tissues, and it's hardly going anywhere. A little bit going up the leg, but that tells us that the blockage is here somewhere at the knee. It's just not going any further. The last imaging is called indocyanine green imaging, or ICG imaging. This is complementary to the last type of imaging, the lymphoscintigraphy. So they utilize this to help plan for the lymphovenous anastomosis. It shows the cutaneous, so the more superficial stuff, whereas the lymphscintigraphy will get as deep as the collectors or the lymph nodes. This allows us for more targeted treatment strategies. I literally just watched a webinar about how they're utilizing the results of this to have their manual lymph drainage done in certain directions. So this is 4 different images of somebody that's had this ICG green, and you can see why it's called ICG green, because it comes out green. This is done under fluoroscope. So there's a handheld wand, for lack of better terminology. The green is injected here at the hand, and then they follow it up to see where it goes. And then they do the mapping afterwards. So all of this here tells us that this is where things are just getting hung up. It's not going any further. But because they've injected this green, you can see a line here and a line here that's dumping into this armpit area. So the therapist would know to treat and move the fluid into that area. And the same thing with this one. Again, a lot here dumped in the forearm, but you can see it coming up here just, whoops, just above this lady's collarbone. So they map it out and the therapist would be gearing their treatment towards hitting there. Lots in this one in here, and this is coming across this person's chest. So the therapist would be looking to drive it across in that direction. And the same thing with this one, it's coming across and they map it right out. So is really, really helpful, and is also, again, helpful for them to determine where they might want to do that anastomosis. So where would they tie in the lymph vessels most effectively to the veins to make this move a little bit easier. So what do you need to know? What's your takeaway for today? Risk reduction strategies are supported by a paper that was put up by the National Lymphedema Network. These are lifelong risk factors. So if you are someone who is at risk because of a cancer diagnosis, radiation, obesity, etc., these are things you want to avoid as much as you possibly can for the remainder of your life. You want to avoid any kind of puncture wound on your involved extremity, your at-risk extremity. So do not have IVs, injections, blood draws on that extremity. And try also, don't have blood pressure done on that side. You want to protect against cuts and scrapes. If you're a gardener, wear gloves. If you're somebody that is exposing yourself at risk because you do a lot of woodworking, again, wear gloves, long sleeves. If you're a hiker, go out with long sleeves on. Make sure that you're active. Be cognizant of your exercise level. We know that people who have more exercise in their lives have less of a chance. Try to avoid any kind of limb constriction. And that's not talking about compression garments. Things that are actually made for this purpose are appropriate. But if you are at risk and you are someone who wears blouses that have really, really tight elastic bands on the wrist, or watch bands that are really tight, you want to avoid that. You want to talk to someone about, maybe if you're somebody that flies frequently, maybe a compression garment is appropriate for air travel. We know that in a cabin of a plane, we all swell up a little bit. So if you're at risk for lymphedema, it might be appropriate for you to be wearing compression just on the plane. And you want to avoid extremes of temperature. So on a hot day like today, you don't want to be sitting out in the sun doing a lot of heavy yard work for prolonged periods without giving yourself a chance to cool off. So, important takeaway number 2, when do you want to act? So as I mentioned earlier, if you have an awareness of any swelling or size change in your involved arm or leg, that's when it's time to contact a lymphedema therapist or your doctor. If you have a sense of heaviness, aching, fatigue in the limb, if you're noticing that all of a sudden you're not able to move the limb as well as you used to be able to, if you're developing frequent infections, if you're noticing a change in the texture of the skin, if it just doesn't feel right, or oftentimes the people that I see preoperatively and immediately postoperatively, I always tell them, if there's anything in your limb that doesn't feel normal to you, that's when it's time to reach out to me. It can be a phone call, it can be an actual in-person visit, but if something doesn't feel right, don't take a chance. Contact somebody who can help you through that. Don't just leave it to time and see what happens. Because that's when we can do things, is when it's the earliest. I appreciate your time and your attention and the opportunity, again, from the Breast Cancer Network as well as the Windsong Cares Foundation. A great opportunity for me. And if there's any questions, I'm happy to answer them at this time.
I don't see any in the chat box. So the question is, oh, okay, we do have a question from Catherine. Go ahead and unmute yourself, Catherine.
Oops. Hi, thank you so much. That was really helpful. My question is about strategies for talking to other medical professionals. I can never get anyone to do a blood draw on the side with the least lymph nodes missing, because the veins there are not as easy to get. But I've also, so that's a phlebotomist, but I've also had an anesthesiologist who had an absolute tantrum because he had to put an IV in my neck. It's like, I can't help it. So how best to address other medical professionals about this risk? They don't all seem to understand it. Thank you.
Yeah, that's a very common complaint. I hear that oftentimes. And unfortunately, those risk reduction strategies that's put out by the National Lymphedema Network, there's no proof on any of them. And that's the problem. We know that anecdotally, these things seem to potentially lead some people to kind of go over that cliff and develop the symptoms of lymphedema. So without that scientific proof, there's a lot of people in the medical community that will poo-poo it and just say, well, you don't need to worry about that. There's no proof to that. I think all you can do is just be very, very insistent and say, listen, it's my body. I know what I've been told. I am not going to tolerate you telling me that I have to do it this way or that way, or I will find somebody else.
Yep, simple as that. That's all you gotta do.
Simple as that.
Donna, I have a couple other questions that came in via chat. One is, can you define cording?
Can I time what? You can define what? I'm sorry.
Define cording, C-O-R-D-I-N-G.
Okay, excellent question. Cording or axillary webbing syndrome is a pretty common phenomenon, mostly following lumpectomies. There are the occasional mastectomy patients that develop this. And it is just what it sounds like. It looks like a cord, excuse me, or a guitar string. When it's considered webbing, it actually almost looks like a spider web, typically in somebody's armpit area. It can actually go all the way down, where's my camera? Down the upper arm. I have seen it go all the way down into the forearm. And it is just a band of tissue that when the arm is extended out and away from the body, just jumps right out and grabs you. There's various theories about whether or not we need to do anything about that. Some trains of thought think that it'll go away by itself, and it probably will. Some trains of thought think you ought to have a therapist take a look at it and do some soft tissue mobilization. And I have done that many times, and it can be very effective. They have determined that it is definitely a vessel. It is not 100% determined if it's a lymphatic vessel or if it's a blood vessel. Most of what I've read seems to think it's probably a combination of the two. But most of the folks that I have seen that have it, it goes away. And it's not, again, it can be uncomfortable, but it's generally not horribly painful. I think having some intervention and have some soft tissue work done speeds up the process, but more than likely it'll go away on its own, even if you don't. But if you're not stretching it and moving it, it won't go away.
Another question is, do you help with lymphedema in the legs?
Yes. Same
Okay.
process as I went over with this. It's the same steps. It's the manual lymph drainage. It's the compression. It's the patient education, etc. It's just the opposite part of the body.
Okay. And another question, how risky is it to have surgery on the shoulder of the affected limb?
Also, good question. If it's something that needs to be done, you definitely want to do it. Again, take the precautions, make sure that you're aware of any changes in the limb. Following the surgery, chances are, depending on, I've got a loaded answer here. Most cases of lymphedema are going to happen within the first 3 years of surgery and treatment. But again, the risk reduction, the risk factors are in place for life. So you need to think about it. If it's a procedure that really isn't necessary, then you can live with your symptoms. You might want to think long and hard about it. If you've blown out your rotator cuff and you're in pain all the time and you can't sleep at night and you can't use your arm, it's probably worth doing it if you don't have any symptoms. There's people that I've treated that have had carpal tunnel syndrome treated, and haven't had any problems. It all depends on the status that you're at and what you're comfortable doing. But I
Another-
would, again, if the symptoms are bad enough and you really need shoulder surgery, do it. It probably does not increase your risk any significantly.
Do you think we have some hands raised here? I just want to make sure we're, Catherine, did we answer your question? I think you, Amy, and Kate had
Yeah,
raised
yes,
your
you-
hands.
This
Okay,
is Catherine. Yes, you did. Thank you.
okay, just want to make sure we had everybody covered. A couple other questions is, do you know if there's anyone in the South Towns that is doing lymphedema treatment?
To my knowledge, no.
No.
None that I know of, no.
And then another question, I love going for a massage to relieve stress. Do you have, or can you recommend a body massage therapist who is familiar with lymphedema?
We have a massage therapist here at our office that I work closely with. If a lymphedema patient or someone who's at risk comes in and is interested in a massage, she always consults with me. I don't know if there's anybody specifically that I would recommend other than her, but she's the one that I'm most familiar with, of course. And if you do have a massage, there's no reason that you can't go to pretty much anybody. But when you go to a massage therapist, you should always make it very clear before they get started. Let's say it's your right arm that you're at risk of developing lymphedema in. You want to make it clear to them that they should only do superficial work on that extremity. So you don't want them in there kneading and really digging at the muscle tissue. You want them, everywhere else is fair game. But the arm that's at risk, tell them to go lightly on.
I think you answered the next question then. Is it safe to have a full body massage after mastectomy?
Absolutely.
Or could this lead to lymphedema?
Nope.
No, okay. And it looks like we have actually a local oncology massage therapist who has joined us. Her name is Amy Hartle.
Hey there. Can everyone hear me?
Hi, Amy.
Can you hear- Oh, hi there. Hi, Donna. That was an awesome presentation. Thank you so much. And I did just want to chime in since a couple of people had asked. I am in downtown Buffalo. I have been a practicing oncology massage therapist for 9 years. I'm also certified in manual lymphatic drainage. I'm not a CLT, meaning I don't do what Donna talked about with wrapping and garment fitting and all of that, but I do manual lymphatic drainage. I've also went through breast cancer in 2017, and that has been the bulk of my practice for 9 years is women impacted by breast cancer. So I'm happy to talk one-on-one with anyone who has questions, but just to kind of sum up also and piggyback on what Donna said is that I do recommend that if you have any kind of cancer history, ideally, it's important to see someone who has at least foundational oncology massage training, because while yes, a lot of the times most of the body is fair game other than the compromised quadrant or area where the lymphedema risk is present, there are still other things that can be going on based on treatments that you've had, like chemotherapy can have long-term effects like bone fragility, risk of osteoporosis. Radiation can create fibrotic tissue, and not just in the breast or in the lymphatic vessels. So there are actually a few of us in the area. There's not many, but I can recommend someone who I know is oncology trained. Actually, there's at least 2 people in the Williamsville area, and I'm downtown Buffalo. I also know a couple other lymphatic drainage therapists around. So happy to
That's
answer
great.
any questions. Yeah,
Thank
and
you,
I'm
Kate.
yeah, absolutely. And I'm actually I'm joining the board for the Breast Cancer Network of Western New York, and I'm going to be heavily involved with setting up the education series going forward for the coming year. So I'll make sure that things like bodywork, massage therapy, and all of that gets included so that we can get more information about those types of questions.
And it's probably a good time to mention that the Breast Cancer Network does have another session coming up. Donna, would you mind speaking to that?
Yes, on June 8th, again at 6:30, we're going to have another session where I'm going to do just a quick overview of lymphedema, and we're going to focus mostly on exercise and how to appropriately exercise following a cancer diagnosis / lymphedema diagnosis at risk for lymphedema diagnosis, and the importance of doing regular exercise and how it can benefit you.
And I have one more comment, actually. Someone has stated that they had lymphovenous bypass surgery on their left arm and hand, and so far so good. And that was on 4/9. No longer feel heaviness in the arm, hand does swell, was told it takes a few months to heal. Stage 1 left arm lymphedema.
Was that done locally? Whoever answered that question?
Can you respond in the chat?
Oh, yes. I went through Dr. Fry, Jordan Fry, ECMC.
Mhm.
I gotta talk to you because I'm up for it myself and I'm scared.
Oh, that was the easiest. I went for the deep procedure, the breast reconstruction. So the hand little thing in my arm is nothing. It was very easy. That part was very easy.
Okay, Terry, this is Kate. I will ask you down the road, but I have another question. If anybody can does anybody know where you can have blood drawn other than your arms? I ended up in Suburban and they got PO'd because they sent me down to the triage because it was the only place that could take the blood out other than the arms, because Quest nor Kaleida will take it out other than the arms.
Hmm.
May not be a question that we can answer.
Okay, I was wondering if anybody else ran into the same problem and had an idea of where else to go.
Yeah. So it looks like we've answered all the questions in the chat. Does anyone else have a question for Dr. Gulick?
No.
And I will remind you that I did put in the chat a little survey. It's very helpful for us to get feedback on these types of sessions. So if you wouldn't mind taking the time to answer that, that would be great. We do have one more question, and Donna, I can tell you many people have said this has been very informative. They're asking if there are any support groups for lymphedema in the legs.
I know there had been just a general support group for lymphedema that was being hosted by Sheridan Surgical. I don't know if that's still going on or not. I know I'm not even sure about the health and well-being of the woman that facilitated that. But I know that most of those people involved with that group were lower extremity cases. So you might call Sheridan Surgical to see if that's still functioning. But I have not heard anything about it in a while.
And someone saying they don't see the survey. It would be right at the very top of the whole chat. You'd have to scroll back up. You can also find the survey link in your calendar invite that you received, the Zoom calendar invite. It should be there as well. Any other questions?
No.
All right. Well, thanks so much, Dr. Gulick. Again, thank you so much for a wonderful presentation. I think everyone found it extremely informative. And
Great.
Amy, thank you as well for joining us.
Yes, thank you. Thank you, Amy and Donna.
Thank you.
Thank you very much.
All righty. Bye-bye now.
Night, everyone.
Bye-bye.